Today is the fifth session in our whole webinar series that is titled Community Health Workers, Frontiers of Thinking and Evidence webinar series. This series is hosted by Oxford Policy Management and Women in Global Health, the India chapter, which is a collective to talk about actually the gender and associated issues in the domain of global health. This series aims to synthesize and really talk about and discuss evidence from research, policy, and practice to collectively deliberate on the experiences of CHW engagement in India. And with this, we also aim to gather insights that would inform future policies and programs. Across the series, our approach has been to include voices of different stakeholders. That's why we've had health workers to researchers to practitioners and policymakers and also civil society members. It's really to understand how different perspectives play out on any issues. Till now, we have touched upon various aspects related to community health workers and community health worker programs. Our discussions have revolved around issues of empowerment, power dynamics, the use of technology, and also how community health workers really navigate the complexities that exist in the community that they serve. The key insights from the first four webinars have really made us to understand that and really reiterated the fact that CHWs are highly intrinsically motivated and empowered group of health human resource that serves the community. Since they serve the community they are from, they are also vulnerable to the gender and social location that they possess. So thus, the health system really needs to account for the aspects that ensure a rights-based approach in CHW-related programs and policies. We also had a discussion on leveraging technology and digital interventions to enable CHW's performance and really support them and enhance their work. Our discussions have continuously emphasized in the fact that CHWs are the primary end users and many digital tools need to account for issues of digital infrastructure, quality training, and reporting burden as well. In this pandemic times, we actually had a last session on talking about the role of CHWs in building resilient systems. We deliberated on what roles that they played and how did they really cope during the whole shock of the pandemic. One of the key messages that emerged from that discussion was that resilience building within the health system needs to be looked at not only one-time exercise during a crisis, but actually as an ongoing process of strengthening community process and state support. To summarize this discussion and also to move forward and take this discussion to our current session, which is on supportive supervision. Today, our session is actually about talking at supportive supervision practice at length. Look at evidence and practice around in India as well as globally. We hope to talk about the imperatives of institutionalizing supportive supervision and discuss the issues associated with sustainability and practice of supportive supervision at scale. Today, I'm privileged to really welcome our panelists and we are very glad to have with us Dr. Marie Spoke as our keynote speaker. She is one of the prominent global health researchers on community health workers. She's based out of Malawi and affiliated to KIT Royal Tropical Institute in Amsterdam. Her work is well known for actually understanding and contributing understanding the factors that influence CHW performance. More recently, she has been leading a research on impact of supportive supervision on CHWs in Ethiopia, Kenya, Malawi, and Mozambique. Our second panelist is Ms. Sudesh Namkarji. She has a rich experience across the development sector in developing communication strategies for social development programs at national and state level and resource mobilization. She has consulted at national and state level with multiple stakeholders around capacity buildings of service providers and direct implementation at the grassroots level. At present, she heads the social and behavior change communication practice in Piramal Swasthya. Next, we have Dr. Himanshu Bhushan. He is currently heading the Public Health Administration Division in National Health System Resource Center, which is a technical support wing to the Ministry of Health and Family Welfare, Government of India. He was formerly the Deputy Commissioner and Head of the Maternal Health Division in the ministry. And he has a rich and diverse experience, both as a clinician and as a public health expert. He has spearheaded many policy initiatives associated with maternal and child health. Dr. Bhushan has worn many hats, including being a member secretary of various task forces on comprehensive primary health care. He has been instrumental in designing and implementing various critical public health policy decisions. Next, we have Dr. Suchi Srinivasan, a fellow colleague who is a health systems researcher with an interdisciplinary background in social policy. She has a background in undertaking implementation research and mixed method evaluations of public health and health worker programs across India. She works as a consultant at OPM and the technical lead on the Frontline Worker Grant at OPM. Her current research focuses on health system strengthening through improved performance of health systems providers. For this session, we have Tom Newton as our moderator. He's an independent health systems consultant who focuses on what it takes to improve the performance of health systems and providers. Tom has formerly been the country director at Oxford Policy Management in Delhi and the principal investigator of a learning grant looking at what it takes to improve the performance of CHWs in India. I welcome you all and thank you everybody for giving time for this session. I hand over now to Tom to really carry forward the session. Thank you.
Great, thank you, Arpana, and thank you to everyone who's joining us today. Hope we have a productive and engaging session. Over the next hour or so, we're going to roughly split this webinar into 4 sections. Firstly, we're going to look a little bit at the state of supervision globally and in India. Then we're going to move on to explore evidence on some recent interventions that have tried to improve the effectiveness of supervision. Then the panel will reflect a little bit on what that means for policy and a research agenda. And then we'll open it up to hopefully everyone's thoughts and questions for the last 20 minutes or so. Just before we jump into the first session, I'm just going to put up one sort of framing slide, just to sort of define what we mean by supportive supervision, just as an alignment before we start the discussions. So all throughout these webinars, we've been using this conceptual framework of means, motive, and opportunity to look at the determinants of community health worker performance. So we've argued that community health workers perform if they have the means, the ability to perform, the motives, the desire to perform, and most importantly, the opportunity to perform. That the system gives them the resources and opportunities that they need to be able to fulfill their jobs. And in most of the previous sessions, we've seen how really it's the opportunity, or lack of opportunity due to system level constraints, that are really the main binding constraints to performance of community health workers in the context that we've been looking at. Why we're so interested in supportive supervision, or supervision in general, is that in theory it should be addressing all 3 of these determinants of performance at the same time. So by supportive supervision, the 3 elements we define firstly as coaching and capacity building of community health workers to improve their knowledge and skills and improve their means to perform. Supportive supervision should also include support community health workers in resolving the problems that they face higher up at the system level. And then supportive supervision should include the 3rd element of appropriate management, the right balance of sticks, levers, and empowerment that motivate and give community health workers the desire to perform. So in theory, good supervision, supportive supervision should include all 3 of these elements: the coaching and capacity building, support to resolving problems, and appropriate management. And thus it should address all 3 of these means, motive, and opportunity buckets that determine performance. So that's in theory. In the first session, we're going to get a sense of what the state of supervision is for community health workers globally and in India, and how that affects their lived realities. So firstly, I'm going to hand over to Maurice Koch, who's one of the leading global experts on these issues, has been particularly studying supervision in East and Southern Africa. So Maurice, would you like to sort of give us a brief overview of the state of supervision that you found in your research, and maybe reflect a little bit also on the drivers of supervisory styles that you found?
Thanks, Tom. Yes, I will. And thank you for inviting me for this webinar. Yes, I think globally there's a lot of research on community health workers in the past decades, and it is shown that supervision has room for improvement generally. And we also found that in our studies in Africa. I have particularly been studying Ethiopia, Kenya, Malawi, and Mozambique as part of a Reach Out consortium over the past years. And we found that supervision was irregular and often focused on fault finding. And these were really demotivating factors for community health workers. So if you look at supervision, and I think it's already also in this framework that you have been showing, it generally contains of 3 domains: the management or administration domain, development, including learning, and then the support. And the supportive part of supervision can include a lot of things. It's about mentoring, it's about strengthening relationships between different actors, it's about identification and solution of problems, for example, related to supplies, incentives, or service delivery related, but also about promoting teamwork and communication. So it really includes a lot. And what we have seen in our studies, and I think also other studies globally, is that supervision tends to focus more on the administrative and management part and less on the supportive and learning development elements. And yeah, why is that? Well, there is often little funding and support to really make supervision happening. So then it is somehow easier to focus on the more administrative and supportive parts of supervision, because this data needs to be, brought to the upper level. And that is also partly a result of how programs are being shaped, because there is a lot of focus nowadays on like measurable indicators. How many clients have community health workers reached, and how many medicines have they distributed, and that all needs to be recorded, and it needs to be reported and brought it up to the monitoring systems. And that is important, of course, but it is not the only function of supervision that is there. We also see that in many countries there's a lack of embedment of community health workers as such within the health system, and that makes it also that their supervision is also sometimes more like an add-on to the job of maybe a health facility manager or a nurse that have a lot of other things to do and maybe no time, and also did not receive the appropriate training or coaching to really conduct this job. And what we have also seen in some of the African countries is that supervision of community health workers is quite scattered, in that they need to, they have different supervisors for different programs within the government, but also within the NGO sector. And that makes supervision also not integrated with each other, which is also a problem. Other problems are like lack of clarities on the roles of the supervisor, but also of the community health workers, and also a lack of insight of the context in which a community health worker is actually working. Frequent turnover of supervisors we have seen in our studies, like that we train, like implementation studies, we train the supervisors and then, they move elsewhere, and then, you have to train again. And sometimes gender issues. Supervisors in some settings are more often male, while community health workers are more often female. And on its own, that might not be a problem, but in some context and related to some issues, it can be. So, if you're talking about punitive supervision, sometimes we are talking about that. It could also be really related to cultural norms and practices. Somehow, like in settings where hierarchy is very important and where the upper level, so to say, is used to to tell the other level what to do and what not to do, and also to really pinpoint more on the negative instead of the positive. It is happening, and it undermines trust, and it undermines credibility of community health workers. Well, yeah, and then if we're talking about supportive supervision, it is really about promoting quality at all levels in the health system. It is about identification and resolution of problems. It's about relationships, and it's about making most use of the available resources that are there. This is from a definition of Marquez and Kane in 2002. So supportive supervision really focuses more on it's more about humanized support instead of like managerial control. And I think there is quite a lot of evidence out there that supportive supervision is more effective in increasing job satisfaction, in increasing motivation and performance than the more, let's say, the traditional supervision that is more focused on the management and recording and administration. And what is seen, I think, from our studies, but also from others, that the mechanisms that is leading to this positive outcomes is really about trusting relationships between supervisor and supervisee, but also other actors. It's about team spirit, open communication, and if a community health worker gets supportive supervision, it is also giving credibility to the community health workers, also in the eyes of the community. So I think that's what I had to say for now. Thanks.
Great, thank you, Maurice. So I'd like to bring in Suchi, who's led various pieces of research looking at supervision of community health workers in India. So Suchi, would you like to reflect on whether you see some of the same issues that Maurice has talked about how important supportive supervision is, but how supervisory styles actually tend to be quite fault-finding, control-heavy, management-heavy, demotivating, and driven by a large number of system-level factors?
Yes, thanks for that question, Tom. And a very good afternoon, everyone. So globally, we see that supportive supervision surfaced in community health systems literature in early 2000s, where supportive supervision was discussed as a critical parameter for program implementation support. Even in the context of India, it has been discussed since 2005, specifically from the lens of its support for immunization coverage, for WASH initiatives, for control of spread of diseases. So the literature, when we look at it, is about 16 years old and has since discussed many of the challenges that Maurice has just outlined, wherein we see that where supervision is unsupportive, it's demotivating, it's punitive in nature. And a few of these reports are also summarized on your screen, as you can see right now, where we see these two specific cadres of health workers in India, which is the auxiliary nurse midwife, or the ANM, and the Anganwadi worker, or the AEWW, who discuss this reprimand and humiliation that they face. And this also surfaces in the broader literature. This is most problematic because it's also a commentary on the relationship between the health worker and the supervisor, which in recent research we see is very essential to empower the health worker to deliver, to be coached, to be given the necessary knowledge, the skills, to forge those trusting relationships with the community, much in line with what Maurice has just pointed out. But what we see with regard to what affects the supervisory styles in India is also it's also a factor of certain systemic and cultural factors which are very specific to India, and these interact and overlap to affect the nature of supervision delivered. When we start with, say, systemic factors, we see that evidence indicates that supervisors insist on checking registers, and reporting culture is institutionalized because even a block level manager needs to bring forth some metrics to be reported to his or her supervisor. So there's an excessive focus on mapping these statistics and metrics, for instance, antenatal care coverage, immunization coverage, and it often overlooks the effort that goes behind getting that statistic in that register. This one specific study from 2016 in Haryana actually pointed this out, where the community health worker said that I don't think the effort I put in is ever being recognized. So supervision offered is very task oriented, and it's not necessarily geared towards mentorship. And this is partly also affected by the structure of supervision in India. Now, when we look at the three cadres of community health workers, the accredited social health activist or ASHA, the A&M and the Anganwadi worker, now these health workers are mapped to a population of 1,000 to 5,000 persons. And these health workers are further line managed by an immediate supervisor who takes care of 20 to 30 supervisees each. These immediate supervisors are line managed by a block supervisor who again looks at the performance of 20 to 30 supervisees each. So the average caseload per supervisor is very high, which often makes a very facilitative and supportive style of supervision hard to implement. And these numeric challenges are further compounded by vacancies that exist. So standing supervisors have to deal with additional burden of greater number of supervisees. Specifically, when we look at one specific cadre of health workers, which is ASHAs, she's line managed for various aspects of her performance by 3 to 4 different supervisors, one of whom is an A&M, who herself is a community health worker. So this particular CHW/supervisor has a dual burden of line managing the ASHA and also addressing the beneficiary's needs. So all of these factors make it challenging for supervision to be supportive. In terms of individual level aspects, like Marie's pointed out, research increasingly tells us that CHWs look to supervisors for knowledge, for problem-solving skills, for on-site support, for feedback on their performance. However, our evidence tells us that technical knowledge deficits exist even at the supervisory level. Some of our data from OPM's work from 2016 tells us that the knowledge levels of supervisors of Anganwadi workers were almost comparable with that of their community health workers. Even in terms of the training for skills that they go through, we see that there's a deficit in terms of soft skill or transferable skill training. So managerial skills are also lower because they're predominantly trained on program implementation and not managing and coaching and mentoring their subordinates. Finally, when we look at some cultural and historical aspects, in the case of ASHAs specifically, we see that the line management and the reporting hierarchy is, it started surfacing in government documents and literature where the concept of an ASHA facilitator was identified back in 2012-13, if I'm not mistaken. And few states have institutionalized a cadre of ASHA facilitators as late as 2018. So our knowledge about their competencies, about their strengths, and what mechanisms can be used to strengthen the supervision they offer are also restrictive. Another aspect in terms of cultural aspects is also how the nature of supervision that, say, an ASHA receives is mostly driven towards program outcomes, so institutional deliveries, home-based newborn care. And this is what determines her training as well as her supervision. A 2016 study from Manipur actually documented this. And when you look at the ASHA, she's considered a social health activist. So there's very little supervision on how she can develop that aspect of her performance because the supervisors themselves haven't been trained on polishing that element of the health worker's performance. And finally, well, there is evidence to say that supervisors do act supportively, particularly to new recruits, giving them the necessary knowledge, the necessary skills when they're new on their job. But the challenge that limits their performance and the nature of supervision they deliver is the fact that they don't have much autonomy and agency to, say, solve problems, to reward good performance, to sanction poor performance. And this limits the performance management systems in place. Partly a reason for this is the fact that National Health Mission is predominantly constituted of contractual staff, and that may potentially also affect the agency many of these line managers have. So together, all these aspects are likely to drive the nature of supervision offered. Thank you.
Great, thank you. Some really fascinating insights and really echoes some of the global literature that Maurice introduced. So I think in both of those presentations, really clear messages coming out that supervision tends to actually be quite punitive, audit focused and counterproductive. But also there are lots of very multifaceted and complex reasons why supervisors act the way that they do, driven by factors at the system level, cultural norms, all kinds of factors. So I think this is a good time to go over to Himanshu from a policymaker's perspective. I wonder if you could reflect a little bit on what you've been hearing from Maurice and Suchi, on why we see the kind of norms of punitive and counterproductive supervision that have been set out by Maurice and Suchi.
So good, great. And I was listening to the panelists, and also I was going through the vignette 1 and 2. So first of all, I would like to place on the record that this is completely a wrong notion that nowadays this supportive supervision is punitive in action. We have more than 10 lakhs ASAs in the country, and one or two, some sporadic incidents I will quote about that, should not be granted as the notion for the countrywide ASAs available. Because before the launch of the National Health Mission, it was more monitoring. And when it comes to monitoring, then usually the tendency was always to fix accountability someone below you. So I did everything fine and someone below us did something wrong. National Health Mission, when it was launched as National Rural Health Mission in 2005, completely changed this word monitoring to supportive supervision. All of you know, when we talk of the supportive supervision, means I go there in the field, I see what you are doing, how you are doing. And in case you are not doing it properly, then I will also, instead of chiding you, I will also mentor you and tell you what in a better way you can do it further. So this is the whole paradigm shift which has been brought under the National Health Mission. This is number one. Now number two, when it comes to supportive supervision, I will rather say that community health worker and particularly the ASA program in the community is one of the best supportive supervision model, which is not there in any program in the country. At the lowest level, that is the ASA, you have a block ASA, you have an ASA facilitator for 20 ASAs. Above that, you also have mentors and guides like ANMs and CHO. You have then a block program officer who is looking after only the community process. Then a district community program officer. Then a state community program officer. So a whole chain is there. And I can tell you with my field experience of visiting more than 400 or 500 districts in the country, that ASA program is one program which is being supported because of the good work that they are doing by right from all the people in the ground to the politicians or to the bureaucrats or to the administrator. So everybody is supporting. So this program, I can tell you, certainly is not punitive in action. Rather, it is very, very supportive. Everybody wants to support their career progression, their incentives. When the program was initially launched, it was completely performance based. So if you do certain performance and then only you get. Nowadays 1,000 rupees, 1,000 every ASA is getting, because certain performance is not being monitored. You have to just say that the performance you have done basic things and you get it. But you have to also understand the role of the supervisors, because a supervisor is at present beyond this chain of the ASA supervisor. There are other supervisors like ANMs, medical officers at the PhD level. They are also overworked. And because of the overwork, sometimes it so happens that the quality of mentoring is not adequate. This I agree. And this also, like some of the panelists has said, that capacity building of the ASA supervisors also needs to improve for mentoring. This is agreed. And several steps are being taken to improve it. Like, we are trying to place the HR as per the IPHS norm, so that the adequate number of human resources are available for the supportive supervision. We are coming out with a tool, e-tool for e-supportive supervision, so that a systemic approach is undertaken for any type of supervision, and then that if there is some gap, how to fill those gaps. So I will not say that the actions are punitive, but some of the vignettes that you have indicated, like delayed payment, there might be some sporadic instances where, because of some reason, the funds from the higher level to the lower level, from the state to district or district to block, has not come on time, and because of that payment is delayed. But for making the payment on time, online payment system is there now. It is a direct transfer to the account of the ASA, no cash, nothing, so that there is no middleman in between. So those actions have been taken for getting the timely payment of the ASA. Besides that, if still there is some grievance at a district level, there is a ASA grievance cell exclusively created for ASA, and then there is also a systemic grievance cell through the 104 centralized call center, which 30 states have implemented 104 centralized call center. Therein also the grievances can be registered, and then it will be added. So what I will say, that ASA is a big force in the field, and their tireless efforts are being recognized by every section of the people and the society. So there is no question of any punitive supervision as far as ASA is concerned. Certainly one thing has happened. Initially in 2005, when the ASA program was launched, it was basically launched for maternal and child program. It was there for improving maternal and child program. Nowadays, because of the good work being done by the ASA, so many other programs have been given to them. It has two aspects. One, positive is their incentives have increased. From, if you will compare from 2005, their incentives have increased to 5 times. But then the negative aspect, if at all you will say it is negative, then workload on the program has also increased on this. But they have a flexi working hour. They are not supposed to work like 9 to 5, so they can work as per their comfort and in their own village. So that way many flexibilities have been given to the ASA program. And now the public health management cadre is coming out, which will take care of the better career pathways for the CHOs, for the ASAs, for the ANMs. So many policy actions are in pipeline, which will take which will improve further progress. As far as a point was raised about the contractual staff under NHM, we have to understand health is a state subject, and regular staff can only be hired by the state. Rather, NHM has augmented the service delivery capacity by giving this flexibility to the states, that you can hire the contractual staff, you can give better incentive, you can give better salary. So many more flexibilities have been inbuilt in the under the NHM, which the states have taken benefit of this, and that has helped also in building the technical capacity, managerial role. Even the ASA programs for the capacity building, it is a small modules. It is not a very big, large module that you will not understand. In so many phases, in so many days, we have from the national level, we have a program that how the reorientation, reorientation, and as a result, ASAs are quite knowledgeable if you go in the field. So that is all I would like to convey in the first round, that the ASA program, the ANM program, particularly the ASA program, is a very good example of the good supportive supervision, and it is certainly not in punitive direction. Thank you.
Great, thank you, Dr. Bhushan. That's a really important perspective. I think everyone acknowledges the sort of tremendous impact that the ASHA program's had over the last 15 years as the world's largest community health worker program. And I think we've always been struck by how sort of advanced the sort of guidelines in the system are. I mean, there's been supportive supervision guidelines for ASHAs for, I think, nearly 15 years. And I think it's that recognition, as you say, that the system intends to be supportive, but in places where the system is most stretched, where there's high vacancies, where there's high workloads, it can fall sometimes in practice below the sort of intended standards and level of supportiveness, and as shown by some of the vignettes presented by the other panelists. And we'll get on to some of the sort of exciting government reforms that you mentioned that are trying to sort of further improve the supervisory system and sort of bring it back to that stated ideal in the third session. But meanwhile, for the second section, we're just going to look at some of the evidence globally and in India of interventions that have been done outside of the government system or supporting the government system to try and make supervision more supportive and meet some of these policy ideals that have come down from NHM and its equivalent in other countries. So we're going to start with a brief look at some of the evidence from Eastern and Southern Africa. So I'll hand back to Maurice.
Thanks, Tom. Well, yeah, how to improve supervision and how to make it more supportive. I think many studies have been looking at it, and implementation studies, as we have also been doing. Often people think about frequency of supervision and duration, but it is after all the quality of the interaction that matters most, I think. And I just wanted to highlight some of the different types of supervision that we could distinguish, like individual, group, peer, community, mHealth supervision, and they can be used alongside each other. And that is also what is happening, and that is what you are seeing also, well, in our study and in other studies, that this type of approaches are put on top of regular supervision, or they are changed in a certain way, and then it's looked at whether it is increasing motivation or performance, and what is the reaction of community health workers about that. So individual supervision is the most common form. It is more like a district or facility-based staff having the responsibility to supervise an X number of community health workers, and often that is done at an individual basis. But you can also think about group supervision, where such a supervisor takes a group of people at the same time, and then they exchange. In our study, we introduced group supervision, and we also introduced peer supervision. So that is really that among community health workers, they have meetings to problem solve, to troubleshoot, to help each other. And that is often led by a more senior community health worker. And in our study in the 4 countries that I was talking about before, we really saw that group supervision and peer supervision made supervision more, let's say, from fault finding to problem solving. Also, it encouraged teamwork. It also led to coordination of tasks, and even in some settings, sharing workload. So if a certain community health worker had a lot on the plate, then others would jump in. Also, other professionals would jump in if that was needed. It also led to increased accountability of community health workers towards each other and towards the organization that they are working for, whether that is an NGO or the government, and towards the community, because after all, this accountability goes both sides. And I think peer supervision could also provide an opportunity for career advancement for community health workers, where high-performing community health workers can take on new supervisory roles. So we have been looking at that mainly, group supervision and peer supervision. We are currently also looking at supervision from the side of the community in Kenya. I think this is well known, and it's a structure that is there in many countries where certain community structures, like for example, village health committees or community health committees, have a role to play in supporting and also supervising and monitoring the work of community health workers. We actually see in Kenya, for example, that these committees are also get very little support. And therefore, their function is also quite limited, and they are quite constrained in, actually performing their role in the supervisory role. When it comes to mobile technologies, I think there are quite some studies on this, mostly more in a pilot setting. National big programs are also there. We also see dedicated supervision. I think an example is Liberia, that after the Ebola epidemic there, they installed dedicated supervisors of community health workers. So they are people that have no other task to do. They are really focusing on supervision of community health workers only. And that's an interesting model. Maybe also resource intensive, and there have no effectiveness studies been done yet. And then I also wanted to still stress self-assessment. We tried to introduce it in our implementation research in Malawi, but it was hardly used, maybe also because people are not used to doing self-assessments on top of other types of supervision. But it is an interesting thought and an opportunity for empowerment via self-reflection as well. Well, how can you make supervision more supportive? Well, you can also think, of course, about job descriptions, qualifications of supervisors, training and coaching of supervisors, making sure that there's enough transport, all these kind of things that we know. In this slide here, I put a theoretical framework that we used in our study in Southern Africa about how supportive supervision could potentially lead to better performance or higher performance. And on the left side, you see like the elements of supportive supervision according to Marquez and Kane. So it's really about what I've been talking about before: problem solving, joint responsibilities and teamwork, learning from each other, also empowering health workers to do self-assessments and to discuss amongst themselves what they think should improve. And then also you can see participation in decision making. We looked at that, but we found that to be still quite limited. So that is something to think about. And really that role as the external supervisor, that is maybe more facilitative, more mentoring and coaching, and not necessarily really the person that is telling what to do or what not to do. So these are the elements of supportive supervision that we looked at. And then the assumption is that it could increase organizational and community commitment of community health workers. And because after all, community health workers are in between the health sector and the community. And also job satisfaction and ultimately their performance. But to really make this happen, in a pilot setting, we saw that there were good results after 1 year. But to really make it happen in a scaled program, yeah, you do need a long-term vision and resources. And the last point that I wanted to say, and I think also one of the attendees already stressed it, that there are other program and intervention elements that are equally important and that also have a bearing on supervision. So we're talking about proper incentives for community health workers, supplies being available, community engagement structures being functional, and all these things are also very important. So I just wanted to say, like, yeah, efforts to enhance supervision without addressing some of these other program elements can really fall short. Thank you.
Great, thank you. And I think this, you know, the framework, the sort of characteristics of supportive supervision really fit in well with what Dr. Bhushan was saying about the sort of intent of NHM and the guidelines for how supervisors are expected to deal with ASHs. And I think as all the panelists have shared and as sort of starting to come up in some of the chat comments, the importance of investing in supporting, mentoring, training the supervisors themselves to equip them to be able to deliver supervision with these characteristics. So on that note, I want to hand over to Sudesh from PSMRI, who've been leading a very large scale program working very closely with NHM to try and sort of roll out training and support to supervisors and their managers to try and realize this NHM vision of supported supervision at all levels. So Sudeshna, it'd be great if you can talk us through what PSMRI have been doing and what your experience has been.
Thanks, Tom, and a warm welcome to all the participants. Pyramid Swasth, as we like to be called, we actually started work in aspirational districts, the 25 aspirational districts, which are primarily districts which were the lowest of the Human Development Index. And our work has been resting on 4 pillars. So these are capacity building, facility-based intervention, community engagement, and effective scheme implementation, government schemes. So the first pillar, which is about capacity building, so here we include capacity building of frontline workers and also that of their supervisors. So what we realized, and some of Suchi has brought forward, Madis has also said things in Africa that's happening. We also do encounter similar things in India as well. So an important component was to improve monitoring and providing supervision that is supportive in nature. So around 5,000 plus supervisors are there in these 25 districts. We are doing various interventions. So when we commenced our work in 2018, we realized that the supervisors seldom visit these village health and sanitation, VHSNDs, which is village health, sanitation and nutrition days. These are once a month fixed day to provide service on maternal and child health in a village. And so from then in 2018, if we look today, almost 12,548 such sessions are being monitored or visited by the supervisors, which is extensive coverage at this point in time, which has been possible because of our constant work with the supervisors, not only in a formal capacity building training rooms, but in a continuous interaction. And I'll share some of those with you. So our whole approach to supportive supervision has been that how do we make the supervisors, as they are sometimes seen as inspectors, because there is a reporting system, they also need to report measurable indicators. How do we make them from inspectors to managers, then to mentors and coach and leaders? So we need to understand this part takes time. It is not one session, 2 session. It's a continuous process, continuous interaction. So we identified the bottlenecks. We realized that the job roles of the supervisors were more towards technical, process related, and certain areas which are softer skills like communication or the behavioral aspect or mentoring, leadership, say, problem solving kind of approach. Those were missing in a way. When we spoke to supervisors, we realized that they were not much aware of the different supervisory styles. They were just doing it what they thought is the best way to do it. And they were more bothered about their day-to-day job responsibilities. So that kind of hampers the supervisor-supervisee relationship. So we try to strengthen that relationship and bring it more supportive in nature. So this intervention, actually we address more as a softer skills, but contextualized it to the regular activities so that they could relate. So my first session with supervisors on a training was when the supervisor said, I don't have the time. I need to tell my frontline worker what to do. There is so little time to do things because they are under pressure. And at the end of the 3-day session, he said, I do appreciate what you're saying. Yes, I need to look at the way I interact with my supervisee. I need to sit together, understand, problem solve together. Yes, it needs time, but I'll do it. And we've seen that happening in the field. So, which is a great thing. That's a shift in 3 days. And then you see things happening in the field as well. So in terms of model, what we did was we worked to complement and supplement Government of India's work. We strengthened the public health system of Government of India. So the whole idea was to create a set of master trainers who were from these districts itself. So we identified the district supervisors, district officials, and we held a TOT, training of trainers, in the 7 states. The 25 districts are spread across 7 states. Then 7 TOTs we did, and they became in turn the master trainers who trained the district level training and block level training. So we covered supervisors who were immediate supervisors of the frontline workers, whom we call as sectoral supervisors, the block supervisors, and the district supervisors were primarily the master trainers. So that's an asset we created within the district itself. We supported the training of master trainers, and then the entire budget for district and block level training came from the government. And that's where we try to institutionalize things because, as I said, these trainings have to be ongoing. It cannot be one-off kind of a thing. So till date, we could train around 1,679 supervisors. We started the work in August 2019. Unfortunately, we had to give a pause in March 2020. As we all know, the pandemic had hit. Now we are thinking of redoing it again. We will be starting the training of the supervisors again, but step it up a little bit. So that's from my end, Tom. Thanks.
Great, thank you, Sudesh. And it's so exciting, the PSMRI work, because it's a rare example of a supportive supervision intervention at scale across so many districts through government systems. So such an important initiative, but also such an important contribution to the global evidence base on how supportive supervision can be strengthened at scale through government systems. So, I mean, alongside some of the initial rollout, Suchi's been leading an evaluation, a process evaluation, working closely with PSMRI. So Suchi, do you want to, would you tell us some of the highlights from the process evaluation?
Thanks, Tom. So PSMRI carried out the intervention to strengthen the supervision received by ASHAs, Anganwadi workers and ANMs, focusing on skill-based training of the immediate supervisors, that is the sectoral supervisors, and the block level supervisors across the 3 corridors. We carried out a process evaluation across 4 states of Madhya Pradesh, Jharkhand, Bihar, and Rajasthan to document how the process was rolled out and what was the effect of this rollout. We carried out this study through a qualitative route and about 56 interviews across designers, implementers, recipients of the training, and the supervisees of the training. And our findings were structured around 3 verticals: the design elements, the delivery aspect, and the impact. So to start with the delivery aspect, what we noticed was that the one thing that came up very strongly was that the training content was very widely accepted because it was seen to be very novel. Now, most training that community health workers and their supervisors go through are mostly program driven or service delivery driven. So this was the first time that very novel concepts of basic techno-managerial skills like communication, leadership, team building, practicing and planning supportive supervision were introduced. So the recall value of these aspects was very high. What also made it easier was the fact that most of this content was packaged with very interactive messaging. So using Bollywood movies or pop culture references and games, so that there's a higher retention of these concepts. However, specific to design, what also was voiced by the recipients of the training was a need for more technical skills like time management, task prioritization, negotiation, which goes on to explain that supervisors recognize that they need a broader set of professional skills in order to be effective. Moving on to the delivery side, one thing that PSMRI did was take into account that vacancies can create a challenge in supervision. And they addressed this by also training the functional supervisors. So community health workers' supervision is not interrupted regardless of vacancies, which is a good design parameter to account for, especially given high attrition rates in certain geographies. PSMRI also did this other thing wherein they combined all three cadres of health workers together. And this had a very positive impact on the morale of certain groups, such as ASHA facilitators, who felt it was one of the few platforms where they were made to sit with the other supervisors and their role was sort of given in accordance with the other supervisors as well. But what also emerged, and as Sudesh has also pointed out, is the fact that follow-up is very critical. And no matter how strongly packaged the training, the impact is likely to taper off. And what it needed was a refresher training and also continued on-site support through coaching and mentoring measures. In terms of impact, we did notice some nascent self-reported changes in the behavior of the supervisors, both at the sector and the block level, where they acknowledged the fact that they had punitive tendencies, that earlier I used to scream if I didn't have the time to explain the challenge, but now I'm a little more understanding. However, community health workers could not see any discernible differences in their supervisor's attitude. And this is likely to be corrected with, say, refresher trainings. A very unusual finding that came from this intervention was that supervisors continued to view supportive supervision as an independent activity. So while they acknowledge that, yes, it's very important, I need to be supportive, but I don't have the time to do it. So it's indicative of the time burden of being supportive and also of how the messaging of supportive supervision needs to be presented. Not as something that is an independent module, but overlaid in their everyday health and nutrition specific duties. Another aspect coming from the burden aspect is how some supervisors said that it's very hard for me to be kind and supportive and also chase deadlines, which goes on to also discuss the emotional burden that they face in dealing with their deliverables and being supportive at the same time. So all in all, PSMRI's intervention, as Tom, you also pointed out, is a very unique route which also populates very deficient literature in the space of skill-based training of supervisors to make them supportive. And it also demonstrates how this can be done in a scalable fashion. I think the biggest advantage of such an intervention was that it led supervisors to acknowledge their poor practices and acknowledge the need to correct it and be more supportive. Yeah, that's all I have for you. Thanks.
Great, thank you. And there was a question in the chat about whether there are sort of write-ups of the evaluation and intervention, and a link has been pasted if anyone wants to find out some more. Great. So I mean, just sort of one final round before we go to the Q&A. It's really quite an intimidating list of questions facing the panelists. But I did want to circle back to firstly to Dr. Bhushan. of course, you've been instrumental in sort of setting the architecture for supervision under NHM and for setting out the supported supervision guidelines. And you mentioned earlier that there were sort of exciting interventions being planned by the government to sort of further strengthen supervision in line with that original intent, including in several states the rolling out public health management cadres. So I was wondering if you could sort of tell us a bit more about the sort of policy reforms being considered at scale by the government.
Very interesting discussions, and most of the points, being said is also known to the policymakers. And as Sudesh very rightly pointed out, that, and even the study quoted by Suchi was also, very well said. See, the softer skills, that is very important. And I have no hesitation in saying that in a public health facility, this is lacking. It's not only at the ASA level that we are talking of. If we go to any level, probably the type of software skills which should be applied while you deal with the patients, or you are dealing with your seniors, supervisors, coordinator. So this is not adequately or properly covered. One of the reasons, we have to go to the basic reasons why it is so, and there are the reasons which some of the points the study conducted by Suchi also has said. One is that quantum of work. So if you see the WHO standards for the medical workforce to the population, which is 44.5 vis-a-vis in India, it is less than half. And the volume of the population and the need of the population, the vastness of the population, that you fully understand. So this is also one of the reasons that if you have to choose, like the guidelines are very well defined. The supportive vision guideline says that what should be the frequency of a medical officer visiting the field, what should be the frequency of a block medical officer, block program officer going to the field, how the lady health visitors should supervise. For every 6 ANMs, one lady health visitor is there. In every block, there should be a block public health nurse, district public health nurse. So the system is defined, but the enough number of manpower is not there because, so this is one gap. And that's why those who are there are so if a doctor is there and if he has to choose between seeing the patient and undertaking the supervision, naturally he cannot ignore the patient first. So he will first of all attend to his clinical requirements, then go into the field. When it comes imbibing the softer skills, so then in the curriculum itself, if you talk of a nursing curriculum, if you talk of a pre-service curriculum of an MBBS doctor or any other such cadre, I feel that in the curriculum itself, the software skill needs to be built in. And there should be, those type of interactions so that it is imbibed. And then we have to give a right environment. So everything plays. It's not that, I can point out that on the one hand, I agree that the software skills part, probably in the public health facilities and public health working is a little bit compromised than in many other areas. But then you have to also understand that, public, health facilities or even here, it is more open to the public. When you go to a private health setup, then it is more close to the public. They will, you will know only such information which they would like to give you. Here it's quite open. Anybody can walk in, anybody can go in and get the information. So those stress are also there in the public, and that is fine. That is welcome because we don't have any issues. There is no hide and seek game. So having said this, then what all we are trying to do for doing this. So again, I agree with what Suchi said, that whenever our technical contents are very good, and it's all modulated, a small 2 days, 3 days, modules are there. Now the focus on the software skills have come in a big way, and those are also we are trying to imbibe, and that's why to improve the capacity building, to improve the knowledge platform, not only the ASA network of knowledge is being created, but also the latest technologies are being used, like Government of India IGOT platform, you must be knowing about it. Now teleconsultation is being promoted through hub and spoke model in all over the country, and now it is coming in a big way. And even not only that, good quality fiber optic lines are being connected through the Department of Telecom for improving the network related problem. So all these efforts will certainly help in improving the capacity building. But there is one more systemic gap which probably we need to fill in, and we are trying to do that. What happens that plan should be systemic. When we come to a district health, the district health should have an action plan, district health action plan. And if the district health action plan is there, and if the role which is envisaged in that plan by the concerned people, if they are trying to do and achieve those roles adequately, then the burden is not there at one place. So whatever burdens that we are seeing, that see, particularly if we talk of the ASA, she is not responsible for improving our quality ANC. She is not responsible for improving the any quality parameter of it. Her job is very simple. Her job is to motivate the people so that they come to your health facility. If they are coming to your health facility, it is our job to provide the good quality services. So if somebody is trying to see that if ANC has not taken place, it is ASA's responsibility. If BP is not taken place, it is ASA. It is completely wrong. It's not there. It's not in the guideline. It's a different sort of action that people are doing, and we don't support it. What we are saying is that program is defined, job responsibilities are defined, and ASA is only a link between the community and the health system. ASA is there that in case of any red flag sign, that person comes. If home-based newborn care is there, if 6 visits are to be done to a home, and if a red flag sign is there, then just ask the mother or the parent to come to our health system. That is her job. That's all. And that way, I am really proud to say that ASAs are doing their job very well. I should not say it right now. It's not the forum, because still there are the groups, there are the people who now strongly feel that this is the time when instead of one ASA, a second ASA should be brought in, because the workload which has generated at the grassroots level is now enormous, and probably we need more than one ASA. But then if any number is multiplied, it also multiplies certain challenges. The present incentives being earned by the ASA, that will also be shared if we give you more numbers. And the present incentive is fine, not that bad. But then if this incentive is divided into 2, then probably it becomes less. So there are many considerations, but I will not say that at policy level, but there are the groups, there are the people who strongly believe that we need probably to speak up, because NCD program has come in a big way. Communicable disease and the public health surveillance need that you are seeing in the country because of this pandemic has come in a big way. So there are the issues related at the community level, and there are the issues which needs more focused attention. So these things are coming up. not being considered right now at the policy level, because it has both pros and cons and it needs further discussion. But in nutshell, what I would like to say that if you talk of a research and study, kindly undertake the research on time motion, studies, where you can. There are some studies which have already been undertaken, which are 2, 3, 4 years back. So you can undertake, latest studies of time motion for ASA, for CHWs, for the ANMs, and see that how much time they have and how much time they are devoting to the people. So that is the one area. Then I will say that study on the workload to the supervisors. So if you people can come out with some good documentary evidence on the workload of the supervisor, then also the quality of trainings, which particularly the study which Suchi brought out, that how to address these quality in our capacity building exercise, and will artificial intelligence help it to the grassroots level worker like the CHO and other people. We are already doing, taking help of many technologies to help the CHW performing her job in a better way. Besides the guideline, technical tools and lab tests, point of care tests are being supported at the level of the health and wellness center, so that our community health workers perform in a better way. And even we are coming out with a tool when a particular case has come, and if he feels that at a particular point, she needs a consultation, then she can connect and get all those things done. So these are some of the studies, along with gaps in the supportive supervision. Those studies can help in some of the policy decisions, particularly regarding the adequacy of the manpower, capacity building, career progression pathways that you are seeing right now, which is available for the ANMs or the ASA. That will then if they are contractual, as some of the vignettes have said, versus if they are regular. So you can do a study and compare. Does the study come out with any evidence or think that those who are regular are working better, or those who are contractual, they are working better? So I mean, it's a government dilemma. Contractual versus regular is a big government dilemma. People are not. I am just saying, it's nowhere written. It's a dilemma, because if I make you permanent and if you don't work, then my teeth are less in government system. And if you are, contractual, then the teeth is more. This is a wrong notion. This is exploitation. I agree with that. I am not in favor of this. Neither the policy of government of India is in favor of this. But then these studies will probably indicate that how to improve these balances. There can be more, and we can have a brainstorming session on what all studies. But I will also suggest that whenever some studies are being undertaken, if we are in the planning stage, if our views are being taken, then the quality of the study and its outcome will be good. So you are free to think about it, involve us or our institute in that area for good quality. I know that you people must be doing a very good quality research, but still that will help So these are some of our view. But whatever I am saying here in this webinar is my personal view, and based on my experience and knowledge on the policy. My views are not the views of the government of India, because I am not a spokesperson of the government of India, and so this is my personal view. Of course, I have contributed to many of the policy decisions. I know about many of the policy things which are going on, but then ultimately, view expressed here is by my view in the personal capacity. Thank you so much.
Sure, all understood, Dr. Bhushan, and thank you so much. I mean, firstly, the sort of research agenda that's most useful to government, I think, is incredibly well received, and thank you also, I think, for sort of pulling out some themes that have come out of all of the webinars that we've been doing. You know, really about how difficult the job of ASHAs and other community health workers and their supervisors are, how much responsibility and workload is placed on them. And how the sort of responsibility of those supporting them, development partners, researchers and government, their responsibility to try and give them every chance to be successful in difficult and challenging roles. So thank you for that. I'd like to move to opening up some Q&A. I will come back to Sudesh right at the end as a sort of way forward. But I would like to take some of the questions. There's lots in the chat. I wanted to start with one specific one that was in the Q&A that Maurice would like to answer. Look specifically at sort of individual or self-supervision, which is something that we haven't covered in detail today.
Yes, I was referring to that, and I just wanted to say to the one that came up with this that please contact me. We did experiment with this in Malawi, a self-assessment form, and I think I can share that to the one that was interested, so I can keep it very short. Thank you.
Great, thank you. Okay, so lots of very difficult questions coming up. So one of the questions, I mean, of a different type of supervision after self-supervision is around peer mentoring. And I was wondering if, I mean, Maurice, probably with your global experience, you've seen this in action, and whether you had any reflections on whether it's something that should be piloted or tried in India.
Well, yes, I think in Ethiopia and Malawi, where we did it, it had good outcomes. If you combine it with the other type of supervision, like group supervision or the individual supervision, it really made a difference for the community health workers. They felt very much, empowered, and they felt more teamwork and more problem solving together, more accountability towards each other and towards the organization. So I think this is an approach that could be tried. I'm very well aware. I think we have quite a lot of attendees that are also really pointing towards the fact that in many areas and also ASHAs, they are not having a full salary. We all know that. And to what extent can you really expect that they should be supervised? That's the first thing. And that you should also ask other tasks on top of what they are doing, like, for example, peer supervision. But I think it can definitely help, because it brings people more in power, and it brings people having a voice in what they think should maybe change, or they can what should be reported to higher authorities, or what can help them in the job. So I do think it can also help, even though you are working in a voluntary community health worker program. That having said, there is a need to really consider seriously remuneration of community health workers according to the tasks that they are doing, as also recommended by the WHO in their guidelines. Thanks.
Great, thank you. And of course, there's so much heterogeneity across states in India, which is always important to take into account. One of the things that comes up across a number of questions and a number of themes in the presentations is the role of data, and the fact that there's a lot of time spent collecting service statistics, which flow upwards and are really used in quite punitive ways to sort of audit performance, not really used for genuine sort of quality improvement at the front levels. And there's always lots of demands to see how data systems can be rationalized. I wonder if you know, Sudeshna, through the work that PSMRI have been doing, or Suchi from your research in India or elsewhere, or Himanshu from your policy experience, if there are any sort of concrete examples of that you've seen of sort of successful initiatives to reduce the sort of burden and drudgery of reporting and to use it in more constructive ways.
So then you have asked me to respond.
Oh, any of the panelists, but why don't you go first?
Okay. So see, as far as the ASA program is concerned, the community level, this workers program, reporting format is not envisaged to be implemented for the ASA. They are not, you know, well qualified, very literate people. They can be illiterate also in some of the tribal belt. You know, their qualification have been relaxed. Now, sometimes it so happens, you know, that respective state, district, or even at the block level, somebody, you know, institutes some reporting format for these poor ASA, which is wrong. So ASA is, the ASA formats are very simple. Even she is supposed to come to the ANM, say it verbatim, she maintains a ASA diary, that is more than enough. And in ASA diary, you know, she reports, writes about her program. And if she comes to ANM, she should convert it into the reporting format. So as far as the ASA is concerned, those flexibilities in the national program has been built in. Might be in some states, you know, they have introduced something like that, which normally is not, you know, not promoted as far as that ASA is concerned. As far as the ANMs and the CHOs are concerned, the community health officers are concerned, at the grassroots level, of course, the reporting formats are there, which have been further simplified. There were times when there, if you go to a sub-center, which is now converted into health and wellness center, there were 22 registers. And these 22 registers were to be filled in by these poor ANMs. And in one of my field visit, you know, I saw a ANM carrying 2 big bags of the register. She was not able to, you know, carry it, and then I supported her. I picked up 1 bag, she picked up another bag, and then, you know, I offered her transport, and then she could go. So, you know, those things have now gone. There is only one simple RCH register as far as the RCH program is concerned. And it has a village-wise, you know, register. Now, even those registers have been converted into the portals. And even the ANMs and ASAs have been given those, you know, tablets and mobiles and those type of facilities, so that there is no need to maintain the register. What happens that even I have gone and met the ANMs and ANMs there in the grassroots level, they feel more satisfied in writing the registers. They will do both the job. They are not supposed to do both the job, but they feel more satisfied. They maintain the registers also. They maintain they send the report in the portal also. And even I have met the ANM who are still, you know, filling those old registers which are not being asked. So this needs more, you know, training, capacity building, good quality supervision, and of course it should not be inspectory. This tends to happen sometimes, you know, by default. You start doing inspectory. You are there to do supervision, but you start doing inspectory. You have less time, and as a result, you start. So all these, you know, bad practices which are there in the field, is in the knowledge of the program officers and the policy makers, and slowly using the different technology, latest tool, we are trying to solve these problems. And now the partner support, like support from Pidambar Swast and so many other NGOs and organizations, we are also coming up to help in this direction.
Great, thank you. It's such a, I mean,
Tom,
that's a.
I would like to just take a minute to extend what Dr. Bhushan was saying. So he
Sure.
brought in a very interesting aspect of technology coming in the hands of the frontline workers to do things. And he also highlighted that they are doing both manual entry as well as entry in their smart tabs. Now that's because there is more feeling of control when you have something with you manually. And technology adoption, one big component which has been kind of overlooked for technology adoption is the behavioral component. It's assumed that if we give technology knowledge, the application knowledge, people will understand, run with it and use it. But there is a huge behavioral component in it. And here the supervisors can play a great role for the frontline workers to support them to adopt technology. Thanks. I just wanted to
Thank
share
you.
it.
Such a complex issue. I think that would be worthy of a webinar in itself. Maybe that can be the next one in the series. But thank you. We've come to an end pretty much of the time that we had. So I did want to thank all of the panelists and all of the attendees. I mean, we haven't done justice to the large number of questions. I know Maurice has very kindly said that she's very happy to be contacted and to find out more information about the work that she's been leading, sort of very right at the frontier of thinking on these areas in East and Southern Africa. And she's put in a few links, including some very interesting work they've been doing around measuring supportive supervision in different constructs. So I mean, I thank her on everyone's behalf for being willing to sort of receive lots of follow-ups. I did just want to give one final word to Sudeshna. I mean, there's a lot of interest in the chat and in the Q&A about finding out more about the PSMRI work. I'm going to put you on the spot and sort of assume that you'll be willing for people to follow up. But I mean, it would also be great to hear your thoughts on how people can collaborate with you and your team if they want to.
Yeah. It's we all realize that especially COVID has taught us more that collaboration is the only way out. We all need to collaborate to come out of a situation. Any organization cannot alone do it. Government alone cannot do it. A single NGO cannot do it. Private bodies cannot do it alone. So collaboration is the key thing which we have learned. So surely there is a huge space for collaboration. We are connected with like-minded organizations who are working in the space of supportive supervision, and we try to influence the government's way of looking at it as well as a unified voice, which is very important for all of us. The other thing which I wanted to share with you is, apart from the organization, it's very important that in between two trainings of the supervisors, it's very important to be connected with them through some kind of communication. And so we look for opportunities to do it. I'm very happy to share as an organization. It's a unique initiative. We have created knowledge assets, which are thematic cards for supervisors. Thematic cards can be on early registration of pregnancy, institutional delivery, to SAM, MAM. So there are 12 cards also including COVID. We attend the supervisors meetings. We orient them on it. We highlight their roles and the support they need to give it to the frontline workers and to nudge them to use the mother and child protection card as tools. So these are the opportunities we take to be connected with the supervisors till we meet them again, either on a physical classroom or an online classroom. So going forward, we are planning the next level of capacity building initiatives with the same set of supervisors for a level up. We are looking at a combination of online and offline. Was given the pandemic, it's very uncertain at this point in time. So, happy to join hands, work together, learn from each other, and that's what collaboration is all about. So, Tom, that's the thing I want to leave behind.
Thank you. And I did also want to acknowledge some of the questions in the chat and the Q&A around the sort of unequal power relationships between community health workers and the supervisors and the sort of system functionaries. I mean, we haven't sort of done justice to that issue today. I mean, it's such an important driver of some of the sort of behaviours that we want to change. And we have, of course, in previous sessions looked at some of these aspects of power and empowerment in more detail. I do apologise that we haven't quite sort of managed to get into that in detail today, and I hope that in one of the future webinars we'll come back to that in a much more detailed way, because I mean, these supervisory relationships are inherently human relationships and sort of very much impacted by some of these dimensions of power and gender dimensions of power. So thank you, everyone. I realise we've run out of time. I hope everyone who's attended has got as much out of this as we have as a group of panelists. Learning about why some of the aspirations for the system to be supportive at all levels are not quite realised in some cases because of these systemic constraints, the manpower constraints, workload constraints. And very fascinating sort of dives into some of these very practical interventions that have been piloted around bringing in softer skills, peer supervision, etc., etc. So a big agenda to build on, and do please continue to reach out to our panelists on the research side, Suchi as well, who's sort of really led some of the Indian research on this and different methods of supervision. So thank you very much, everyone, for joining us, and thank you very much to the panelists. Dr. Bhushan, you've got your finger up. Would you like the last word?
So I would just like to thank you, Tom, and also thank the organizers and the fragment and all the panelists for giving me this opportunity and getting interaction with each other. I will on behalf of the NHSRC, I will also like all the giving my thanks to all the participants who have come and listened to us silently. We have not been able to answer even their all questions, so sorry for that. And finally, I will convey my extreme thanks to my colleagues Poonam and Asima, who helped me coordinating this and doing all the research. I was just a mouthpiece. They were talking. So thank you so much. Thanks a lot.
Thank you, and we'll make sure that the materials, the recording, the PowerPoints, etc., will be distributed to everyone who registered and available on the OPM website and linked to any social media posts. And of course, to echo the thanks to the organisers in the background, to Apna, Deepika, and Katriel, and Rishi and others who've supported the hosting of this. Great, thank you.
Thanks to all of you. Bye.
Thanks, everyone.
Thanks everyone for joining in.